I'm Dr. Robin Farias-Eisner, the Academic Chair of the Department of Obstetrics and Gynecology at CHI Health. I also have a couple more roles. I am the Executive Medical Director of the Women's Health Line at CHI Health, and also the Director of GYN Oncology here in the organization. Advancement in treatment for gynecological malignancies has an interesting history. Over the last 4 decades, the efficacy of newer treatments for ovarian cancer has been fairly flat, in the sense that over 40 years, has there been an impact from newer therapies? And unfortunately, the answer is not as much as we would have liked to have seen, in large part because the diagnosis is made so late compared to the other cancers. So specifically for ovarian cancer, what is encouraging, and what I believe to be the future, is a combination of surgery when feasible upfront. So that is to say that we operate and we perform cytoreduction or debulking to remove all visible disease. And in so doing, we leave only microscopic or minimal residual disease behind, which is far more sensitive or receptive or responsive or vulnerable to chemotherapeutic agents. We could use conventional chemotherapeutic agents like carboplatin and Taxol, and that currently is the standard of care in the United States and in developed countries. But on the horizon are newer therapies. Immunotherapies have shown a lot of promise. Targeted therapies have shown a lot of promise as well. I think that in those patients that have refractory or resistant disease, where recurrent disease occurs within the 6 months after completion of therapy, or even during therapy, that is the definition of resistant versus refractory, respectively. Those patients will, I believe, in the future, in the next 5 years or so, we will see other either immuno or targeted therapies. For example, PARP inhibitors, which we have dedicated really exclusively to patients with BRCA1 or 2 deleterious mutations. We're now discovering that PARP inhibitors can be utilized even in the absence of those deleterious mutations. So I do believe that immunotherapy and targeted therapies are the wave of the future. And we are also working on those areas of discovery in my laboratory as well. In terms of endometrial cancer and cervical cancer, newer therapies on the horizon likewise. Fortunately, these cancers are diagnosed early when they're still resectable or surgically treatable. After surgery, these tumors, once removed, we look for, as you know, disease, microscopic disease in the lymph nodes or beyond. And in that setting, then they're treated with adjuvant therapy, usually radiation therapy, and newer forms of radiation therapy like SBIRT, which is stereotactic body intensive modulated radiation therapy, IMRT, which is intensive modulated radiation therapy, are newer modalities to decrease collateral injury to normal tissue and just to focus exclusively on microscopic or even gross disease within the lymph nodes or elsewhere. Both endometrial cancer and cervical cancer can be associated with disease spread to the lymph nodes, even though these tumors and cancers tend to be diagnosed early. Other modalities that I feel are very much within our reach in the next 5 years are other targeted and immunotherapies directed to endometrial and cervical cancer. There's also ways of enhancing the efficacy of the radiation that we administer through combination chemotherapy with radiation. That's called chemosensitization. So one of the encouraging areas that I have focused on in my laboratory, and I believe that will, in the next 5 years, we will see significant traction, is the toxicology profile itself, that the patient will have fewer side effects and not compromise efficacy of the new drugs. That's a focus that we've taken with success And I believe that we're making progress along with other laboratories around the country.